and welcome to another live broadcast with MedStar Health. My name is Sarah Ridenour, and I'm joined by our experts from MedStar Health Gastroenterology in honor of GERD Awareness Week. With holiday season finally here, many of us overindulge, and it can lead to heartburn, bloating, and acid reflux. But when these symptoms occur on a regular basis, despite normal eating habits, you may have GERD, also known as gastroesophageal reflux disease. To learn more about GERD, its risk factors, and how to treat it, keep watching, share this video with your friends, and share your questions in the comments below. Before we get to the questions, let's learn more about our panel of experts. So thank you all for joining us today. We really appreciate it. If you could go around and introduce yourself and tell us about the work you do here at MedStar Health. I'll start with you, Dr. Sloan.
Okay, thanks, Sarah. My name is Dana Sloan. I'm a general gastroenterologist here at MedStar Franklin Square Medical Center. I've been in practice for 19 years. One of my passions is colorectal cancer screening, but I do take care of adult patients for a broad spectrum of GI diseases. I'm glad to be here.
Great, thank you. And Dr. Perengel?
Hi, Jose Perengao. Thanks for having us, Sarah. I joined MedStar in 2020, right at the start of the pandemic. I initially started out in Baltimore, but now spend majority of my time in Annapolis and still time in Federal Hill, a couple days a month. But my focus is primarily on functional bowel disorders. And yes, colon cancer screening, but we definitely do have the ability to take care of a whole host of gastrointestinal disease.
Great, thank you. You and I both started at MedStar at the same time, right in the thick of COVID.
Very good.
Thank you. And Dr. Khan?
Hello, everyone. Thank you for the invite. And I'm Vinci Khan. I'm a general gastroenterologist at MedStar, and I just joined. I'm new to the practice, and I trained at MedStar, and then so I have a connection here. And my interest include functional GI disorders and inflammatory bowel disease. And yes, I do provide services here at MedStar Franklin Square Hospital and MedStar Harbor Hospital. So thank you for the invite.
Great. Yeah. Thank you again for joining us. So let's get into the questions. We'll start with just understanding GERD. So Dr. Sloan, what does GERD stand for?
Well, you gave it away, Sarah.
I did.
Stands for gastroesophageal.
And then how common is it?
Exceptionally common. So GERD is one of those things that, depending upon which population studies you're looking at, can have a prevalence of anywhere from 15 to 30%. So very, very common. One of GI disorders that we see in our practice here.
Okay. And are GERD and acid reflux the same thing, or is acid reflux like a symptom of it? And then what are the symptoms of GERD?
Sure. So the terms are often used interchangeably, right? GERD and acid reflux are often used together in the same sentence, really. But acid reflux is just the event of backwards flow of contents in the stomach coming up into the esophagus. So common symptoms can include heartburn, nausea, belching. Folks will call it indigestion or upper abdominal discomfort. Some patients will have other features such as a dry cough, frequent throat clearing, even difficulty swallowing. So there really is a broad spectrum of symptoms that can be associated with reflux disease and acid reflux. Also things like sore throat, bad breath, again, a whole spectrum of possible symptoms.
Okay, and what causes GERD?
So again, this is really having to do with backwards flow of stomach contents into the esophagus and sometimes or pharynx or the throat. There are risk factors for GERD, which I guess we'll get to shortly. But any that will enable acid to reflux into the esophagus will cause these acid, these GERD symptoms and acid reflux events.
Okay.
Shortly, I think.
Yeah, we will get to that. And then what are the dangers of GERD?
GERD is so common. Most patients with GERD will really complications. For understand, there are times long-term consequences of untreated GERD, including esophagitis or inflammation of the esophagus, esophageal strictures or narrowing, scarring of the esophagus that can result from chronic inflammation, especially in the lower esophagus, other sorts of, again, chronic symptoms, lifestyle impacts. We were going to talk a little bit about the risk of cancer in terms of GERD. Most patients with GERD will never go on to develop esophageal cancer. In fact, we've actually seen the incidence of esophageal cancer decrease substantially over the past couple of years. We are more diligent about screening patients with long-term GERD. Having said that, any patient with swallowing difficulties or a change, an uptick in their GERD symptoms should absolutely seek medical care.
Okay.
Mm.
And, oh, sorry, Dr. Perk, did you have something to add?
Mm.
Oh, sorry. I thought someone else started talking. My bad. So my next question was, is GERD associated with cancer of the esophagus, which you covered? So unless you had anything to add, I'll move on to risk factors.
Jump into that.
Okay, perfect. So Dr. Khan, what are the risk factors for GERD?
Thank you, Sarah. So there are quite a few risk factors, and if we can group them into like certain lifestyle factors, like so people who are obese, they're at a higher risk. Then patients who drink like alcohol, like patient who drink alcohol regularly are at a higher risk for acid reflux. Then smokers, smoking kind of disrupts the esophagus lower sphincter, so that they're at a higher risk. Then certain like medical conditions, like pregnant women are at a higher risk of because of the increased pressure, abdominal pressure. Then patients, there are certain conditions, medical conditions like gastroparesis, which is like kind of paralysis of the stomach, where usually seen in patients who have diabetes, a long-standing diabetes. So the stomach is slow in emptying, so the food stays longer, and then it's easier to reflux back into the esophagus. Then there are certain conditions, like certain anatomical conditions of the structure of the stomach and the esophagus, like hiatal hernia, where it's easier for it's basically the part of the stomach. It's easy to go back up and forth into the chest, so that also predisposes to acid reflux. Certain medications like NSAIDs, which is non-steroidal anti-inflammatory medications, like your over-the-counter Excedrin, Aleve, Motrin, they can increase your risk of things. Certain blood pressure medications like nifedipine, like calcium channel blockers, they are like the amlodipine, nifedipine, they can increase it. Like some conditions like older age can also increase risk of developing or like worsening acid reflux, and like sleep deprivation, eating habits, and so on. There are quite a few, and just working on a combination of like managing your diet and your risk factors can do a lot of improvement in your symptoms, sometimes even without medications.
Okay. And you mentioned age a bit. I was going to ask if that's something you see like a certain age group that it develops like more commonly with, or is it something that can kind of happen to you at any age? Just depends on those other factors, maybe.
I would say like, I like mostly patients have like, kind of like there is the lower esophageal sphincter is what prevents the acid from coming back up into the esophagus. With
Mhm.
age, there is there's like decline in that function.
Mm.
So usually these are patients who have had problems or like acid reflux symptoms, but gradually it has worsened, and they're coming with more like the downstream effects, like trouble swallowing due to a stricture and so on.
Okay. Thank you for explaining that. Dr. Perengao, how can I reduce my risk of developing GERD? Is it caused by a poor diet? And so, we talked switching diet can help with that, or can stress affect your symptoms?
Yeah, of course. Dr. Khan had alluded to some of these risk factors already. The usual suspects: smoking, alcohol. As with the majority of health conditions, they typically play a negative role in the development of that disorder. You asked about diet. There are other things that sometimes we're not cognizant of that can actually contribute to reflux. These include high fat meals. So, for example, we have patients who say, eat a heavy, dinner out, fried food. Invariably, their reflux is worse after such an event. And other things, such as even chocolate, is associated with a higher risk of having flares of reflux. In terms of other risk factors that patients can modify, obesity is a big um, factor in the development of reflux. So there have been studies that have actually demonstrated that obesity by itself is an independent risk factor for the development of GERD. One of the studies that looked at it specifically looked at the patient's BMI, or body mass index. So a higher BMI and a higher waist circumference actually causes a rise in the intragastric pressure. So Dr. Khan had alluded to that fact, and Dr. Sloan as well, where if there's a buildup of that pressure inside your stomach, that can worsen reflux as well. So obesity is something that can be managed potentially in conjunction, with a primary care physician, for example. We've seen a lot of the medications hit the market now that have been very, very effective in controlling patients' weight. We see the Ozempics, the Wegovys, Trilicities. All of these medications have been very successful in controlling diabetes, controlling a patient's weight, and those patients we've actually also seen reduction in their reflux events as well in the office. I think one of the things you had also asked, Sarah, was about stress, and I'm glad you brought that up, because in the GI world, we're now increasingly recognizing that there's a sort of a broader category of disease called disorders of gut-brain interaction, or DGBI. We're acknowledging the very strong relationship between the brain and the gut. So the gut-brain interaction, the gut-brain axis. Um, so for some patients with reflux, there's some sort of psychosocial hypervigilance that can actually occur both ways. So if you're, for example, very anxious, you're hyper vigilant about your reflux events, and that can lead to a feedback loop in between your gut brain interact. That axis that can be very difficult to break at times. It requires a multidisciplinary approach, not just from GI, but behavioral specialists may also help. So yeah, there's definitely lots of things that can contribute to reflux, and that's what we're here for. We help identify those issues and work together with our patients to best manage those modifiable risk factors.
Yeah, that's really interesting. Yeah, and I want to get into treatment next and talk about, best next steps.
Okay.
We'll talk about diagnosis first, so I won't get ahead of myself. But real quick, I want to pause and reintroduce the topic today. Thank you all for joining us. Thanks for tuning in. We're here today discussing everything you need to know about GERD in honor of GERD Awareness Week. I'm joined by our experts from MedStar Health Gastroenterology, and we have more to talk about, so keep watching, share this video with your friends, and if you have any questions, please share them with us in the comments. So, as I said, we're going to get into diagnosis next. We talked about, the common symptoms, but Dr. Parangao, when should someone be concerned about their symptoms and go see a doctor and talk to them?
Yeah, thanks, Sarah. So I think one of the things very important to consider when it comes to reflux, in terms of who would benefit from diagnostics and specifically referral to us in GI. I think Dr. Sloan had talked about what we call alarm symptoms, or the red flags. So that includes developing GERD later on in life. So, for example, you've been healthy all your life, and then suddenly at age 60, 65, you suddenly have reflux symptoms. So that by itself, for us, is considered an alarm symptom.
Mhm.
I think what Dr. Sloan had also mentioned was something about having chronic reflux that becomes refractory. Let's say you're taking your medications, you're doing everything that you're supposed to do, then it just won't go away. That's another reason for us to see them. So there's some more overt, or more obvious alarm signs. Having things stuck in your throat, for example, you can't swallow, or very painful to swallow. If you're throwing up constantly, having blood either in your vomit, or having black looking stools, which is an indication of bleeding. Um, and other subtle things would be if we have, for example, a family history of GI malignancies in the upper part of your GI tract. They should certainly be considered for diagnostics.
Mhm. And so how is it exactly diagnosed? Is it just talking about symptoms? Is there test screenings? What does that look like?
Yeah, so majority of cases fall under clinical. We've talked about how it presents. Some patients do have those classic presentations of having that really bad burning in your chest after a meal, things of that nature. But when we look at diagnostics, we've mentioned patients who would benefit from specific types of diagnostic screening. So if you have a red flag, they're typically sent to GI, and the way we evaluate that further is typically with something called an upper endoscopy,
Mhm.
where you come into one of our surgical centers, as you receive anesthesia, and the scope is just about the size of your pinky, goes down the mouth into the esophagus and into the stomach, first part of the small bowel, to look for any abnormalities associated with reflux. So typically for reflux, uh, classic reflux would actually present with something called esophagitis, or inflammation or irritation of the lower part of the esophagus. Um, but in some cases, it's not as overt as that. But the one advantage of the upper endoscopy over other modalities is that we have the ability to actually take biopsies during the procedure to help further elucidate the underlying conditions, if any. One thing that was briefly discussed earlier was the risk of cancer. So Barrett's esophagus, for example, is something that requires a biopsy to be diagnosed.
Okay. Thank you for explaining that. Now, are some tests more effective than others, or does it kind of just depend on what's best for the patient?
Yeah, yeah. So technically, the upper endoscopy would be the best screening modality, at least to begin with. There are other tests that can be done, but for example, an esophagram, which is done by radiology, is a patient drinks barium, and the photographs are taken of their esophagus as they consume the barium. It can shed light on reflux, but it's still inferior when it comes to reflux. That test is slightly better for certain conditions, but for pure reflux, the endoscopies would still be the best. There are other technologies that are now available to us in both the Annapolis location and Franklin Square locations. When we talk about Barrett's esophagus, there's a new technology that we're able to leverage now during the endoscopies, if necessary, that increases the yield of diagnosing Barrett's esophagus and associated dysplasia up to 200%. So it's now available to use for us in GI, and yeah, at least in both the Annapolis and Franklin Square locations, which is great.
Yeah.
For patients who need more, like for diagnostic dilemmas, where they're difficult to manage. Franklin Square does have other tests called manometry, where we evaluate the pressures inside the esophagus. It's an office-based procedure. And something called the Bravo pH probe. It's essentially an implantable device that's implanted in the lower part of the esophagus. Patient goes home and there's a wireless transponder receiver that records episodes of actual reflux for a 48-hour period. And that's something that's available to us as well in terms of the management of reflux.
Great. Thank you for explaining that.
Mhm.
Let's get into treatment now, Dr. Khan. So is, GERD a treatable disease, and what are the treatment options? Is it, we've talked about diet change, medication. So I guess let's talk about those again, and then maybe how to best, recommend treatment for each patient.
Thank you, Sarah. So yes, GERD is a treatable condition, and it's always it's not just one thing, it's a combination approach. So as mentioned, the lifestyle changes is the cornerstone for any approach to treatment of acid reflux. We ask patients to help lose weight. This is in conjunction with their primary care doctor that we have to work. There are certain medications now that can help with that. So weight loss is one of the biggest predictors for improvement in the reflux symptoms and incidence, or frequency of symptoms. And then the other thing would be having changes in your diet habits, not eating big meals, having smaller meals, especially for dinner, having a gap of at least 2 to 3 hours before you eat and you sleep, and avoiding certain dietary triggers like caffeinated drinks, caffeinated drinks, and then there would be some spicy, fatty foods, more so towards the dinner time, and then quitting smoking, reduction of alcohol, those would help, and sometimes elevating your head of the bed can also help. So those are the lifestyle changes that you can do. And then the next step is also medication. So we have certain antacids, there are certain drugs, prescription drugs, and so on. Most of them can help you with. Antacids are for if you already have symptoms, you can help it neutralize the acid. But these are over the counter, like Tums and Rolaids. Then there are certain other over the counter medications that you can take. If it's happening more and more often, then you see us and we can prescribe you some medications. There are medications called proton pump inhibitors. Then there are H2 blockers, which are antihistamines. They can help us. And then towards the ones which are more severe conditions and more medication resistant, cases of GERD, we send them for surgeries. We can talk more about that, which is Nissen fundoplication surgeries. There are some endoscopic therapies that we can also offer to help, but those are mostly reserved for resistant cases and so on. So that's that.
Okay, yeah, surgery was going to be my next question, if that was an option. So it sounds like it is. And what you were saying, it's best, I guess, for patients who are more advanced or have been dealing with this for longer. Can you talk a little bit more about how you determine whether surgery is the best option for the patient?
So obviously we try the lifestyle changes and the medications. So now we have very good options. We have a new drug on the market, which is potassium competitive acid blockers, PCABs. So they have been along with H2 blockers and the proton pump inhibitors, and with these new medications we are able to control, along with the lifestyle changes, a lot of the patients, their symptoms, they're able to control them, and they they don't have to go towards surgery. So with that being said, if they have to go towards surgery, we have to do an upper endoscopy, as Dr. Parangao mentioned, to kind of get the lay of the land, to see if there are any anatomical factors that can help with in terms of surgery. So patients who have what is called a hiatal hernia, which is, coming back to it, there's a diaphragm. This is a muscle that separates the chest from the abdomen. there is a natural hole in it that allows the esophagus to go down into the abdomen. Sometimes if it is like bigger for some like genetic reasons or so on, the part of the stomach is very easy to go up and down into the chest and increases your risk of acid reflux. Or sometimes if you are like obese, that in itself increases the pressure and kind of presses your stomach into the chest. So for those reasons, I would say that there are like there's called surgical procedures and then endoscopic. So surgical, there is what is called Nissen fundoplication. It is a good treatment for GERD and patients with hiatal hernia. What they basically do is a laparoscopic procedure. It requires a cut and so on. It's done by surgeons. They take the stomach and they kind of wrap around. They create a 360-degree wrap around the esophagus to help reinforce the lower esophageal sphincter so that it doesn't go up and down, and also the reflux doesn't happen so often. So that's one. Then there's for mentioning it, I'll come to it. There's another procedure called Link's procedure, which the thoracic surgeons can do, which is also done laparoscopically, which means that it doesn't require a big cut. It's just small holes. They can do it. It's basically a magnetic bead bracelet or a ring that they kind of place around the esophagus to help reinforce the lower esophageal sphincter. I don't like it so much because it can cause problems with trouble swallowing and so on. Then that's one thing. It's just for mentioning. I'm mentioning it. But there are other like endoscopic approach, which is called TIF, which is TIF, which is transoral incision-less fundoplication. So it is a way of doing Nissen fundoplication, which is done surgically, but we can do endoscopically. There are certain things to it that the patients who have hiatal hernia, which is less than 2 centimeters in length, they can undergo these procedures. Where we go down the mouth, this is an upper endoscopy. We go down the mouth and then we create a 270-degree wrap around, reinforcing the stomach around the esophagus, again to help with the with the function of the lower esophageal sphincter. So those are the things we can do in terms of surgery, but again, this is always in conjunction to lifestyle and medications.
Right. Thank you for explaining that. And Dr. Sloan, what are you most excited for about the future of treatment?
So I think in the interest of time, I'll just briefly summarize what my colleagues have already shared. So as Dr. Parangao mentioned, there are, of course, in these emerging GLP-1 agonists such as Ozempic and Wegovy market, very helpful for our patients who struggle with obesity and can't lose the weight with diet and exercise alone. There are the PCABs that Dr. Khan mentioned, the potassium competitive acid blockers, and of course the endoscopic therapies that she alluded to. So these are new and emerging modalities, typically used in combination in many cases, that can be helpful for patients who have persistent GERD symptoms.
Yeah, thank you. And now we talked about this earlier. Holidays are coming up. What are some suggestions you have for curbing GERD symptoms this Thanksgiving?
Everyone loves the holidays. Everyone loves to eat. It's one of the joys of the holiday season. So having GERD does not restrict you from enjoying your Thanksgiving holiday or whichever holiday you and your family celebrate. So I think some of the takeaways can be to eat early. Eating late is an enemy of GERD. Eat early, eat light. I tell my patients, try to graze. A small plate, 4, 5, 6 times a day is far better for GERD than big meals at breakfast, lunch, and dinner. Avoid your food triggers. So, if fried foods are not the thing for you, steer clear of the deep fried turkey. And watch, of course, your caffeine and alcohol intake around the holidays.
Great, thank you. And I want to end with this. What our final message do each of you have for our viewers after watching this broadcast? I'll start with you, Dr. Sloan.
So again, GERD is extremely common, as we started off by saying. So, but it can increase a person's long-term risk of certain complications. So, something that we can all do, we can all take ownership of avoiding our personal food triggers. Mine may be different than yours. Eating those small, frequent meals, cutting back on tobacco and alcohol, and for any persistent or worsening symptoms, seek care from an experienced GI team.
Great, thank you. I'll go to you next, Dr. Parangao.
Yep, just to echo a lot of the things that have been said earlier today. everything in moderation would be ideal. But if anything arises, we talked about the red flags, alarm symptoms. If any of those develop whatsoever, talk to your primary care doctor to seek a referral to see one of us. That's what we're here for. We're happy to see everyone, and hope everyone's listening today has a happy and meaningful holiday season ahead.
Great, thank you. And Dr. Khan, we'll finish with you.
Okay. So, we have had a long year with us, and it's time to relax, enjoy the time with your family. And we have, all of us have told tips and tricks to help avoid the symptoms, and those should help to enjoy a good, peaceful Thanksgiving dinner. And if you do have symptoms, we are here to help you at MedStar Health. And yep, happy Thanksgiving.
Great, thank you. Well, that wraps up our broadcast. Huge thank you to our experts again for spending time with us today and sharing this important information. And thank you to our viewers for tuning in. To learn more about GERD or to schedule an appointment, please visit, we'll post the link to the website in the comments below, or you can call 443-782-7640. Thanks again and have a great day.
Thank you.
Thank you.